Hello everybody, and welcome to the first lecture of Anatomy 2. Hopefully you've had a chance to watch the video on Blackboard about navigation in Blackboard and going over the syllabus. And hopefully you've discovered the online Unit 1 link in the course materials section. If you click on that, you find the chapters for the Unit 1 for this experience, which are going to be chapters 22, 23, and 24. And there you'll find a reading assignment with each chapter, and you'll also find videos that I will post, some of which will be like this that I have made, and some of them will be those that I have found from the internet and shared with you. And if you watch those and you do the reading assignment and whatever else is posted there, then we should be able to keep up with things. So chapter 22 is the respiratory system. And the respiratory system's job is to provide oxygen for the body and to get rid of carbon dioxide from the body. And it does that with the structures that we see here. So you start with the nose, goes down the pharynx, the larynx, the trachea, out to the lungs, where you'll have actual gas exchange occur. If we start with the nose and the nasal cavity, the nose is the preferred place to actually breathe the air in. But you also would know that it is possible to breathe air in through the mouth, because really the air is going to end up at the same place at the back of the throat either way, regardless whether it came in through the nose or through the mouth. So why would you want to, if possible, breathe through the nose rather than through the mouth? What would be the advantages there, or are there any advantages? The short answer to that is the nose gives you a couple of things that the mouth doesn't really. And the first is filtering of the air. You would know that in your nose there are nose hairs, and those hairs are there to act as a filter. It's not necessarily a highly effective or efficient filter, but it's going to capture some small particles like dust, and certainly is going to trap large particles. So you've probably never inhaled a medium to large size bug through your nose, because they would have gotten captured in those hairs. So it's not highly efficient, but any kind of filtering is better than nothing, and the less junk you inhale into the lungs, the healthier you'll be. Another function that you get in the nasal cavity that you wouldn't necessarily get as much of in the mouth is warming the air and humidifying the air. So the longer the air is in tubing of the body before it gets to the lungs, the warmer it is. And on really cold days, this is when you would notice, when you got ahead of yourself, you breathe in a really deep lungful of nice cold air, and it might actually burn a little bit as it goes in because it's a sudden temperature change. Probably you breathed in through the mouth. If you breathe in through the nose with normal breathing rates, that air will have more opportunity, so a couple of inches more of warming tubing before it reaches the lungs, so that can provide some benefit. Additionally, the longer it is in tubing, the more humidification occurs. So the moisture of the nasal cavity will humidify the air coming into the lungs, and the more humid it is, within reason, the more effective gas exchange can occur in the lungs. So humidification and warming is a nice thing to have. If you breathe in through the mouth, that doesn't mean you're going to have long-term problems. It just means the air is not as warm and it's not as moist when it gets to the lungs. If we look at the passageway of that air from the nasal cavity down towards the lungs, we have the pharynx. And the pharynx is broken into three sections. I'm really not so much concerned about naso, oro, or laryngopharynx, but do keep in mind that they're broken into those categories based on where you are. The important thing is when you reach the end of the pharynx, you come to the larynx. The larynx is going to be the connection between the mouth and nose cavity to the lungs, and there at the larynx we find the epiglottis. So right here in the middle, this flap of tissue right here is the epiglottis. Its job is to decide, does what's coming down the pharynx go down the trachea to the lungs, or does it go down the esophagus to the stomach? Obviously, if you're swallowing food or drink, you don't want that to go to the lungs, So the epiglottis would need to close over the top of the trachea and allow that food to go down the esophagus. If you're breathing in air, you don't need that to go to the lungs. You want it, or rather, you do need it to go to the lungs. You don't need it to go to the stomach, so the epiglottis would remain open, allowing that air to easily go down the larynx to the trachea. Occasionally, that flap doesn't close appropriately, and something you intended to go to the stomach might enter the larynx and trachea. At this point, you're choking on something. Maybe it's some sticky mashed potatoes. And by the way, the solution to that problem is to put more butter in your potatoes and they'll slide right down. They'll also taste a lot better too. So if that particle of something gets into the trachea, it causes blockage. Then you can't breathe. So choking is your body's instinctive response to try to blow that object back out of the trachea and let it reset and hopefully go down the correct way, opening up the airway again. If a little bit of coughing and choking on your own doesn't do the trick for this, you can utilize the Heimlich maneuver. Basically, that is designed to forcefully push the air out of the lungs, hopefully blowing out the obstruction that might be in the trachea. You can do this for someone else, or you can actually do it for yourself utilizing the back of a chair if no one else is there to provide that service for you. Just of interesting note for your trivia night, perhaps, the gentleman who developed the Heimlich maneuver did so many, many years ago, but only used it himself when he was, I believe, in his late 80s, and that would have been about 5 to 7 years ago or so. So he developed the idea, but never actually used it himself until many, many other people had used it over the course of many years. It's just an interesting trivial side note there. Once the air goes down the trachea, we're assuming everything worked properly at the epiglottis. It's going to go to bronchioles, and then those bronchioles will end in alveoli. So you can see here these clusters of air sacs. So the lungs are actually two collections of many, many air sacs each, rather than two large single air sacs. So why would the lungs be two collections of small air sacs rather than two large air sacs? And keep in mind, if they were two large air sacs, the overall volume of the lungs would be larger than it is when it's filled with small air sacs. So clearly there has to be some sort of advantage here. And the advantage is surface area. If the exchange of oxygen and carbon dioxide between the lungs and the blood has to occur across the surface of the alveoli, the more alveoli you have in there, the more surface area you have. So your lungs actually consist of millions of alveoli. So if they were two large air sacs, the surface area would be something probably no more than 20 square feet of surface area. So you would have 20 square feet of tissue to exchange gases. And that might sound like a lot, but if we consider the millions of alveoli the lungs actually consist of, now we're talking about a surface area something around a tennis court. So 20 square feet or a tennis court. Clearly a tennis court has more surface area, so exchange can happen more rapidly and more efficiently. Also, having millions of alveoli, if you lose a few hundred or even thousand due to damage or some other issue, you probably wouldn't even notice. But if you had two large air sacs for lungs and one of those was compromised, that would be a very significant deal. So this introduces some degree of disposability to individual alveoli within the lungs, rather than the large air sacs that we really couldn't do without either one at that point. Because the blood is only in the capillary for a very short period of time as it passes the alveoli, and the gas is only in the alveoli for a very short period of time as well, this exchange process needs to happen very quickly. So in the upper left-hand corner here, we see the clusters of alveoli here, and each alveoli has capillaries wrapped around it. If we go over here to picture B, they've removed the alveoli, leaving the capillaries behind, and you can see that there's a pretty dense capillary bed there. So lots and lots of capillaries wrapping around the alveoli. If we go down here to C, here's an alveoli, and we can see the blood vessels wrapped around it, all the way around, very close. And if we look at those up close here, we can see that we have the capillary and a single cell layer of the alveoli. So each alveoli is a single cell thick. This means for gas exchange, the oxygen going from the lungs to the blood and the carbon dioxide going from the blood to the lungs only has to diffuse across a single cell, and it's a relatively thin cell. So this allows rapid exchange of gases because they're very thin and very, very close to the blood supply. Breathing and lung function is all about pressure. So if we think about the pressure that we live in, we'll call that atmospheric pressure. We can say that for our discussion today, that pressure would be 760. Obviously, where you are in the world will affect atmospheric pressure. The higher you go in altitude, the lower the pressure gets. The lower you go in altitude, the higher it gets. But let's just say 760 for this discussion. So that's the outside pressure. That's the pressure of the air pressing on you. Within the thoracic cavity, where we find the lungs, we have two different pressures to consider here: intrapulmonary pressure and intrapleural pressure. The difference between those would be transpulmonary pressure. So the pressures inside the lungs, if you are not breathing in, have to be at least 760, otherwise air would force its way in. So to breathe in, what you want to do is you want to lower the atmospheric pressure to less than 760. Then air will come rushing in through the nose, down the trachea to the lungs as that pressure drops. Once the pressure inside the lungs reaches 760, then air will stop coming in. And to breathe out, you then have to increase that pressure to greater than 760 inside the thoracic cavity to force the air back out against the atmospheric pressure. So really everything about breathing is about pressure. What might happen if the pressure isn't properly regulated? In the top left here we have a punctured parietal pleura. So something punctured the thoracic cavity itself, but didn't damage the lung. So we've lost the seal on the thoracic cavity, which means that the intrapleural pressure is now no longer properly regulated. So as you try to decrease the pressure in the thoracic cavity, which would normally allow air to come into the lungs, now air can easily come in through that puncture in the thoracic cavity, meaning the intrapleural pressure increases. This makes it perhaps more difficult for that lung to expand because there's a greater pressure there. Air is coming in easily and interfering with inflation of the lung. When you go to breathe out, it's also difficult to deflate the lung because you lose pressure very quickly through that puncture. This would be what is referred to in the field as a sucking chest wound. So if you have a patient who has a sucking chest wound, let's say you're in the field, you're not in the hospital where you have all sorts of fancy tools and equipment, what might you do to immediately provide some treatment for a punctured parietal pleura? This can be as simple as using a plastic Walmart shopping bag or anything that will cover that hole and seal it in a relatively airtight fashion. So something like that, press it in place, put some pressure on it, and that will then seal that hole. That doesn't automatically change all the issues of pressure you have going on inside the thoracic cavity, but it certainly would stop the problem from getting any worse. Then perhaps you can go ahead and get to a hospital or some other facility where it can be properly treated. Another possibility occurs here in the upper right-hand corner, a ruptured visceral pleura. This can be a result of a number of different things, but in this case, the lungs themselves are ruptured, but the thoracic cavity is still intact and sealed. So in this case, what you have is when you decrease the pressure in the thoracic cavity, the lungs start to fill with air, but the air then promptly starts to leak out at that location of rupture, which means the intrapleural pressure is going to increase. your intrapulmonary pressure will decrease, and you basically start filling up that side of the thoracic cavity with air outside the lungs, but not so much air traveling into the lung and being available for gas exchange. Sometimes these will spontaneously seal themselves. So it may occur on its own and may fix itself, or it may develop into a further problem we would then label as a collapsed lung. So at the bottom here we have a scenario where both punctured parietal pleura and ruptured visceral pleura occurred. We would call that a pneumothorax. And in that case, you certainly get a collapsed lung because you have pressure issues both intrapulmonary and intrapleural. So the intrapleural space fills up with air. The lung is leaky, can't fill up. And so you have basically a situation where only one of your lungs is working for breathing. None of these situations we've discussed thus far are immediately life-threatening, assuming you don't have massive bleeding along with it, of course, because you can, for a short period of time, live with just one lung functioning. Obviously, the further the collapsed lung goes, that could move over into the non-punctured area and cause additional pressure there, but you can survive on one lung for a reasonable amount of time. Obviously, the bigger the damage is, the more immediately you need treatment, but these are situations that interfere with breathing, but they don't necessarily have to be immediately fatal. So if we're talking about increasing and decreasing pressures, how is it that we do that? How exactly do we breathe? You've perhaps never thought a whole lot about what is going on when you're breathing. So let's do that for a second. For breathing in, we call that inspiration. So go ahead and take a nice deep breath of air and fill those lungs nice and full, and pay attention to what's happening to the thoracic cavity. Hold that breath for a second, and then let it out. Do that again and think about what's happening to the shoulders. When you breathe in, the shoulders are rising. This helps to pull on the ribs and pull them apart from each other, which would increase the volume of the thoracic cavity. The intercostal muscles, the muscles in between each of the ribs, will relax, allowing the ribs to be pulled further apart by the raising of the shoulders. Also, the diaphragm is going to contract. Before you were breathing in, the diaphragm was relaxed, and it was in a dome or curved position, following the curvature of the lower rib cage. When you breathe in, the diaphragm contracts and flattens out, which means it's pushing the internal organs of the abdominal cavity down and out of the way. This combination of pulling the ribs apart and pushing organs out of the way increases the volume of the thoracic cavity, which lowers the pressure. So this then drops below the 760 and then allows air to come rushing in. So essentially, to breathe in, you're vacuuming air into the lungs by reducing the pressure. To breathe out, we would call that expiration. Everything is going to be undone. The shoulders are going to drop. The intercostal muscles are going to contract, pulling the ribs closer together. The diaphragm relaxes and is pushed back up into a domed position by the pressure of the abdominal organs. This then squeezes the lungs. So to breathe in, we increase the volume and drop the pressure, vacuuming air in. To breathe out, we squeeze the lungs. So vacuum in, squeeze out. Vacuum in, squeeze out. And that's breathing. As you're breathing in and out, we would expect the pressures in the intrapulmonary and intrapleural spaces to change. So as you're breathing in, and let's say a cycle of breathing, so a inspiration and expiration cycle might last about 5 seconds. In the inspiration phase, we see both intrapulmonary and intrapleural pressures dropping. As we increase the volume of the thoracic cavity, we lower the pressure. As the air starts to flow into the lungs and fill them up, we would see the pressure go up until the lungs are full. Then for expiration, we would increase pressure by squeezing the lungs and the intrapleural space. and that would then squeeze the air out. So within that 5-second time, pressure goes down, back up further, then back down in that continuous cycle. So really, breathing is all about pressure. If we consider 3 different possible methods of breathing, in our hypothetical patient 1, we have a normal breathing rate and a normal breathing depth. If we look at the respiratory rate, we have a breathing rate of 20 breaths per minute. That's probably pretty average for sitting in a chair, not a lot of physical activity going on, so relatively average oxygen demand. If we look at the alveolar ventilation rate, we would see that would be 7,000 milliliters per minute. So every minute with those 20 breaths, you would be moving 7,000 milliliters of air in and out, with an effective ventilation percentage of 70%. So not bad. In scenario 2 with slow deep breathing, the respiratory rate might be half what it was for a normal situation, so 10 breaths per minute, with an alveolar ventilation of 8,500 milliliters per minute and an effective ventilation rate of 85%. So actually breathing at half the rate, but a deeper breath, really meaning filling the lungs more fully with air, will give you a greater amount of air in and out every minute and a greater percentage of effective ventilation function. Hypothetical 3, a rapid shallow breathing. Respiratory rate might be double that of the normal rate, but if we look at the alveolar ventilation, it's less than half of what we saw with the slow deep breathing. So breathing at 4 times the rate, but not filling the lungs as full of air, would be less than half the amount of air coming in and out and less than half the effective ventilation percentage. So from a perspective of most effective providing of oxygen to the body, the slow deep breathing clearly wins the job. If you're engaged in normal activities, normal breathing rates are perfectly fine. If you're trying to catch up on oxygen, perhaps after vigorous exercise or something like that, clearly the deep breathing will give you a more effective oxygen supply for the body. We mentioned that time was of the essence because the blood is only in that particular capillary for a short period of time. The gas is only in the alveoli for a short period of time. So here we have a capillary surrounding an alveoli. And from start to finish, the blood is only in that particular capillary for 3/4 of a second before it exits that capillary and heads back out towards the rest of the body. So we have less than a second to capture as much oxygen as possible from the volume in the alveoli and get it into the blood. We only have that amount of time to take as much CO2 as possible out of the blood and put it into the lungs so that in expiration we can breathe that carbon dioxide out. So back to the surface area being so much greater with alveoli, this is where it's important. There's very little time to do the job, and you need all of the available surface area possible to get the job done. Let's think about the breathing rate, we'll call that ventilation, compared to the blood supply or the blood flow through the capillary. At that same time, we'll call that perfusion. So if there is a mismatch between ventilation and perfusion, meaning your breathing rate and the blood supply to the lungs isn't properly matched, then you'll have an increase in carbon dioxide, you'll have a decrease in oxygen or something like that, and that can be a problem. So if the ventilation is less than the perfusion, so there's more blood supply really than there is a breathing rate to support it, what you'll see is that you'll see carbon dioxide go up and you'll see oxygen go down because you're breathing more slowly and you're keeping more CO2, you're not bringing oxygen in. The solution for that from a perfusion perspective, from the blood supply perspective, is to restrict the blood flow to those alveoli so that the breathing rate is now matched to the blood supply rate. Another option might be simply to breathe faster and more deeply. That would increase ventilation and then match perfusion. If in scenario B, ventilation is greater than perfusion, so now we're saying that the breathing rate is greater than the blood supply that goes with it, what we have is we have a decrease in carbon dioxide, we have an increase in oxygen, and while that might sound good, later on we'll talk about respiratory acidosis and alkalosis, and neither one of these scenarios is really good. So from a perfusion perspective, you can increase the blood flow to those capillaries, meaning now we have enough blood to match the breathing rate, or you could lower the ventilation rate, basically slowing down your breathing, which would then match the blood supply. Both of those things might happen simultaneously in those situations. So you can really think about breathing as a 24-hour-a-day, 7-day-a-week process of trying to keep ventilation and perfusion matching each other. The blood carries oxygen on proteins called hemoglobin. And the amount of hemoglobin in your body and in your blood is really a result of your environment. So around here, our environment is what it is. The oxygen concentration in the atmosphere is what it is. And so our body customizes the amount of hemoglobin in the blood to match the amount of oxygen available in the atmosphere. So that means for whatever kind of physical activity you do in the area you live, your body has customized your hemoglobin amounts to be able to effectively capture oxygen for those activities. If you were to go somewhere where the environment was more or less rich in oxygen, the amount of hemoglobin in your blood that would be needed would then change. So let's say that you are able to do a particular physical activity here in the Midwest just fine. Then you go, let's say, to Denver, Colorado, where the elevation is much higher, which means the oxygen concentration in the air is much lower. So your body up to this point was customized with its hemoglobin for the oxygen availability in, let's say, Kentucky or Tennessee. But now you go to the higher elevation, there's less oxygen available, and now you don't have enough hemoglobin to effectively capture it. So you'll very quickly notice that something as simple as walking across the airport and trying to catch your connecting flight then becomes a very vigorous workout that you're out of breath quickly and not able to do well. Doesn't mean you're out of shape. It just means that your hemoglobin levels for that concentration of available oxygen are not adequate. If you were to stay in Denver for a couple of days, let's say up to a week or so, you would then start to notice that what you could do in Kentucky and Tennessee is something that you're now able to do just as well in Denver, because your body has produced more hemoglobin to accommodate that lesser oxygen concentration, meaning that what you breathe into the lungs is more likely to be captured by the lungs if there's more hemoglobin there to capture it. Let's say you then are able to do those activities there and you come back to Kentucky and Tennessee. What you now have is more hemoglobin than you need to capture the oxygen, really meaning that you are somewhat supercharged. You can now capture more oxygen more efficiently, meaning if you could run a mile in Denver comfortably, now you can probably run 2 miles comfortably in Kentucky or Tennessee. That will last for a couple of weeks, and then the body will discover that it doesn't need that much hemoglobin and will reduce the amounts. But for a short period of time, you would notice that supercharged effect. So exactly what's going on in this exchange of gas between the blood and the lungs? Obviously, just by looking at this, your brain might start to melt if you try to keep track of all the chemistry going on here. Don't do that. Just understand that the process of removing CO2 from the blood and putting it into the lungs, or moving oxygen from the lungs into the blood and onto the red blood cell, is a very complicated process. There are a lot of chemical reactions that go on here. So this additionally helps to appreciate the speed and efficiency at which the lungs work for gas exchange. Remember, the blood was there for less than 3/4 of a second. That means in less than 3/4 of a second, you have to drop off the CO2, pick up the oxygen through all these very complicated reactions, and move on. Then you have to go out to the tissues, carry out the opposite reactions, then come back to the lungs and do it all over again. So it sounds simple, but from a chemistry perspective is quite complicated. So just appreciate that gas exchange is complicated. Have you ever noticed that in certain conditions you breathe at a certain rate, and in other conditions you breathe at a different rate? So if you were calmly sitting in class in an ideal situation, and I walked into the classroom and you had a nice resting breathing rate, and then I said, we have a pop quiz. Perhaps it's over something that you didn't prepare for. Or even if you did prepare for it, instinctively the brain starts freaking out a little bit. And you start breathing faster as an automatic response to that scenario. So the brain is really controlling the rate of breathing. And it's doing so a number of different ways. You see here the pontine respiratory center, the ventral respiratory group, the dorsal respiratory group, and the phrenic nerve. That's the nerve going from the brain out to the lungs, telling the diaphragm and the ribs what to do. They're all interacting with each other to regulate how quickly you're breathing, how deeply you're breathing, and how that's all working. So that might be a response to a particular stressor. So that would be perhaps an emotional response. But what if you're not breathing quickly enough, which means you're not getting rid of enough carbon dioxide in the blood? There are chemical receptors throughout the body that monitor how much carbon dioxide is there. And that goes back here to this part of the brainstem. And if that detects increasing amounts of CO2 in the blood, that says you need to breathe faster. So this would be a subconscious, automatic increase in breathing rate simply because you're not getting rid of enough CO2. You wouldn't necessarily notice this, but if you're exercising, your breathing rate goes up, obviously, and that's because your brain was able to detect there's more CO2 than there needs to be. If you speed up your breathing, that will help to dump it out. So that's the normal monitoring, as the brain monitors CO2 levels. Now, I would caution you, if you ever have patients who have respiratory problems, they might be on oxygen. And let's say the patient says to you, I'm short of breath. I'm having a hard time breathing. Can you turn up my oxygen for me? I would suggest that you do not do that, at least not until you consult with a doctor, because the brain normally monitors CO2. But for those people with chronic respiratory problems, they are in what we would call a chronic carbonic state, which means their body is always having a higher than ideal level of CO2 because something about their breathing ability is compromised. The brain eventually says, CO2 is always high. I'm going to ignore that because that doesn't tell me anything. I'm going to look at oxygen concentration now. And the brain would then say, if the oxygen concentration goes too low, breathe more. And this sounds fine, but the problem is if you turn up that patient's oxygen, you superload the blood with oxygen, and the brain then says, there's no need to breathe because the oxygen levels are fine here. When the oxygen levels drop below a certain point, the brain will say, breathe again. From an oxygen perspective, that's fine. But if your breathing continues to slow, carbon dioxide levels keep going up. That introduces a concept known as respiratory acidosis. The entire body is becoming acidic because you're not breathing out the carbon dioxide fast enough. By turning up a person's oxygen, you might actually cause them to enter a coma and die because their breathing rate slowed down enough that CO2 levels built up to the point where they entered a significant case of respiratory acidosis, resulting in respiratory failure, cardiac arrest, and brain death. So simply turning up a person's oxygen might actually kill them. So how do you go about treating this problem if you're not supposed to turn up the oxygen? There's a very simple approach, and it's the same sort of approach you would use when the patient complains the room is too hot or too cold. If you go over to the air conditioning or heating unit and you adjust the temperature, or simply pretend to adjust the temperature, and then ask them, how do you feel now? And they immediately say, oh, that's so much better. Clearly that was a psychological condition. They thought it was bad. They thought it was better when nothing really changed yet. So what you might do is you might pretend to turn up their oxygen levels. And then ask them, how's that? If they then report that, oh, that's better, and they feel better now, that was a psychological condition. They didn't really need more oxygen necessarily. If they still report being short of breath, then perhaps it is a real shortage of oxygen, at which point you would contact the doctor and tell them what's going on. Then the doctor can tell you whether or not to turn up the oxygen, and the doctor hopefully is going to remember this concept of the brain monitoring carbon dioxide and oxygen levels, because you certainly, if the doctor says to turn it up, they should say turn it up a little bit, not a lot. If the doctor says crank it up, you might want to ask them again, are you sure you want to do this? Remember, the patient might be in a persistent carbonic state, and we don't want to kill them. And there have been people over and over who, through good intentions of the uneducated healthcare provider, have caused, at best, brain damage, and in some cases death, because they thought they were helping by turning up the oxygen. So just keep in mind, be careful with adjusting patients' oxygen, because that then impacts the brain's decisions about breathing. So here's that normal process. If the arterial carbon dioxide levels went up, then the brain detects that and trickles out through the medullary respiratory center, the respiratory muscle, increase in ventilation, and the faster you breathe, the faster you dump the CO2 out, and it normally fixes the problem. So the normal feedback is CO2 goes up, breathing rate goes up, CO2 goes down, breathing rate goes down, and everything stays fairly balanced. And again, that's happening 24 hours a day, 7 days a week. You're not necessarily paying attention to it, but it is going on. A couple of other things here I want to mention that didn't necessarily have graphics to go along with it. One of those is the concept of infant respiratory distress syndrome. This is found in the homeostatic imbalance section 22.9 on page 839. Now, always make sure you go through and look at all of the homeostatic imbalance discussions. They typically involve particular problems and a little bit of a description about that particular problem. That's always good reading and is usually quite useful. So infant respiratory distress syndrome occurs when a newborn baby is born, typically quite prematurely, and they're unable to breathe. It's not because they're not trying to breathe, but it's because the lungs have not yet produced surfactant. If you're raising and lowering the pressures to breathe in and to breathe out, the lungs have to then open up and close. Surfactant is lubricating fluid that allows the alveoli to be slippery. So when you breathe out, you're squeezing the alveoli closed. When you breathe in, because they're slippery, they very easily reinflate. If that surfactant has not been produced yet in that prematurely born child, the lungs are sticky. And often the surfactant in the lungs is one of the very last things that's produced before a baby is born. So a premature baby probably hasn't gotten around to that yet. If you expect the baby to be born before full term, the doctor can consider using a steroid injection for the mama, which will increase the baby's lung development rate so that when it's born, it will be able to breathe fine because the surfactant will be there. And as long as they get that injection in probably 24 hours or more before the baby is born, it does provide some significant benefit. For my first child, the doctors had determined long before she was actually born that they could not let her go to term because of problems with mama's health. So they gave that steroid shot, actually about probably 4 to 5 weeks before she was actually born. And when she came out 5 weeks early, normally that would be a respiratory problem, but because that steroid shot had been present with plenty of time for effects, she came out breathing perfectly fine with absolutely no complications of breathing. My second child was not expected to be born early, so there was no steroid treatment done, and she was actually born 5.5 weeks early. So no steroids to accelerate development, 5.5 weeks ahead of time, no surfactant present. So when she was born, she was immediately in respiratory distress because she was trying to breathe, but the alveoli were stuck closed and her lungs couldn't fill. Because they couldn't fill, oxygen levels in the blood were significantly below what they should be. I remember as soon as they realized she wasn't breathing well, they checked her blood oxygen levels, and they were running around 70% of capacity. 70% blood oxygen levels is far below acceptable levels. Really, anything below 95% is concerning. So 70 to 75% is obviously well below that. With manual respirations, they were able to get it up into the low to mid 80s, which was better, but still a problem. So the ultimate diagnosis was there wasn't adequate surfactant. The lungs were stuck closed. And so the treatment was injection of synthetic surfactant, which then made the lungs slippery and immediately allowed the lungs to open up and to take in air. So after 24 hours of my life that I'll never get back, and being on a respirator for that time, after the injection of the surfactant, the lungs worked fine, and after 24 hours they were able to take her off the ventilator. So the surfactant and the timing of its presence is very significant. So the infant respiratory distress syndrome is basically inadequate levels of surfactant in the lungs that fortunately is fixable, typically by 1 to 2 injections of surfactant into the lungs. Typically, once they get the lungs going like that, everything works pretty smoothly after that. So now, 4 years later, you can look at my youngest child and never know that there was any sort of lung problem at all there, as evidenced by the fact of how loud she is when she is unhappy with life, which seems to be, as children are, quite often. Hopefully you have learned and understood a great deal of what we talked about here. Again, if you have questions about either the reading material or anything covered in this particular video, feel free to go to the discussion board for Unit 1 and post those questions there. And I'll try to keep up with that and answer those questions as quickly as I can. Thanks, and have a good day.